All right, welcome to the deep dive. So you've handed us this really comprehensive study guide covering anxiety and obsessive compulsive disorders, and there's a big nursing exam coming up for you. That's a lot of material. So our mission here, we're going to really cut through it all, pull out the absolute must-knows from this guide for that exam. We're zeroing in on, well, patient safety, how you prioritize care, the key things about meds, and essential patient teaching, just what's in this guide. Think of us as your focused review buddies for this session.
Exactly. And this guide, it gives a really solid framework. What's interesting is seeing how these concepts, levels of anxiety, defense mechanisms, they might seem academic, but they actually translate directly into those real-time decisions you make with a patient. So we'll explore how understanding this stuff, just the guide lays it out, helps you assess, plan, and intervene, especially when you need to prioritize and, keep things safe.
Okay, great. Let's start right at the beginning then. The guide makes this key distinction pretty early on. Anxiety versus fear. What's the core difference it's pointing out?
It draws a pretty clear line. Fear, it says, is a reaction to something specific, something identifiable. You see the danger, you react. Anxiety, though, is described as more vague, like a sense of dread or apprehension about something maybe unspecified or unknown. The guide notes it affects personality more deeply.
And it mentions normal anxiety, too, calling it healthy, adaptive. Why is that distinction important for nurses based on this material?
Well, the guide frames normal anxiety as, universal. It's functional. It gives you motivation, that energy you need for survival, for constructive stuff. The real challenge from a nursing standpoint in this guide is seeing when it crosses that line, when it becomes maladaptive, overwhelming. And that's exactly where the guide's breakdown of anxiety levels becomes so practical. It connects directly to prioritizing care, using Peplaw's model that it outlines.
Ah, right. Peplaw's 4 levels: mild, moderate, severe, and panic. This feels like where you start figuring out, okay, what can I actually do for this patient right now? Let's walk through those.
Absolutely. The guide explains how each level really impacts the perceptual field, like what the person can even notice around them and their ability to think clearly or learn. So, mild anxiety. Your perception's sharp. Reality is in focus. Problem solving. Effective. Learning. Optimal. That's like pre-exam jitters, maybe helpful.
Okay.
Then moderate anxiety. The perceptual field narrows. The guide calls it selective inattention. You start missing things. Thinking gets a bit hampered. Learning can happen, but it's not great.
Right, like trying to absorb complex info when you're worried.
Exactly. Then severe anxiety. Perceptual field is way down. Focus might be on scattered details or maybe hyper-focused on just one thing, learning, problem solving. Impossible, the guide says. They might seem dazed, confused.
Okay.
And finally, panic. Most extreme. Perceptual field is incredibly limited, maybe just physical sensations. Learning and problem solving are totally out. Behavior's automatic, just trying to reduce that awful feeling. And the guide specifically mentions the physical symptoms here: palpitations, sweating, trembling, shortness of breath, maybe chest pain. That's a major safety flag.
Okay, so if you encounter a patient in severe anxiety or panic, based on these descriptions, teaching is just not going to happen then.
Not effectively, no. The guide implies your absolute priority shifts. It's about stabilization, immediate safety. They just can't process complex stuff or think rationally in that state. But with mild or moderate anxiety, the guide suggests you can still engage, you can teach, you can do collaborative problem solving because they can still process, even if it's a bit harder in moderate.
Got it. So just assessing where they are on that scale immediately tells you what's possible, what needs to happen first, safety first, especially in severe panic.
Precisely. It's your first filter for how you approach things.
Okay, then the guide shifts to defense mechanisms. These are those automatic coping things, right? Protecting people from anxiety.
Yep. Automatic psychological processes. They help maintain self-image, block difficult feelings. The key thing your source stresses is adaptive versus maladaptive use. Are they helping or hindering?
It lists quite a few. Altruism, compensation, identification, intellectualization, reaction formation, regression, repression, splitting, sublimation, suppression, undoing.
Wow. Can you pull out an example from the guide's quiz section, maybe, showing adaptive use?
Sure. The guide's quiz key uses compensation adaptively. It gives the example of, say, a shorter man who feels maybe a bit inadequate physically. He adaptively compensates by becoming really assertive and successful in business, using that drive constructively to counterbalance the perceived lack. That works.
Okay, that makes sense.
And the guide also notes, importantly, that some are almost always problematic if used heavily, like splitting, seeing things in black and white, all good or all bad. while others, like sublimation channeling unacceptable urges into acceptable things, like sports, are almost always healthy. Recognizing that maladaptive use during your assessment is really key. It signals the patient isn't coping effectively, which, again, influences your prioritization. You'd want to help them find healthier ways. Right, because if their coping is actually making things worse or distorting reality, that's a priority intervention area. Okay, let's touch on the specific disorders mentioned. Separation anxiety, specific phobia, social anxiety, panic disorder, agoraphobia, GAD, and then the OCD-related ones. OCD, body dysmorphic disorder, hoarding, trichotillomania, excoriation. We don't need every detail, but what jumps out from the guide as key features for assessment and definitely safety?
For the anxiety disorders, think about the core fear and how it manifests, as the guide describes. Panic disorder. Those sudden, recurrent panic attacks with intense physical symptoms. We mentioned palpitations, shortness of breath, dizziness, fear of dying. Recognizing that cluster from the guide's descriptions is crucial for quick intervention and ruling out medical issues.
Right, that sounds terrifying for the patient.
It is. Then agoraphobia. That intense fear, places where escape might be hard, public transport, open spaces, crowds. The guide highlights the avoidance. If a patient avoids leaving home, that has huge safety implications. How do they get help in an emergency?
Good point.
And GAD, generalized anxiety disorder. The guide describes it as excessive, pervasive worry that's hard to control and impacts function. That constant worry can really interfere with their ability to focus on, say, patient teaching or following a care plan.
Okay. And for the OCD cluster, obsessions and compulsions are central there, right?
Yes. The source defines obsessions as those intrusive, unwanted thoughts or images causing distress. And compulsions are the repetitive behaviors or mental acts done to try and neutralize that anxiety or prevent something bad, like hand-washing, checking, counting. But the relief is temporary, it says.
So how does that connect to safety and assessment, based on the guide?
Look at the specific behaviors described. Body dysmorphic disorder. Preoccupation with a perceived flaw leading to compulsive checking or camouflaging. You might assess for skin damage from procedures. Hoarding disorder. The guide describes accumulating possessions until living spaces are unusable. Think safety hazards, fire risk, sanitation issues, falls due to clutter. Those are immediate nursing assessments.
Yeah, hoarding sounds like a major safety risk.
Definitely. And trichotillomania, hair pulling, and excoriation, skin picking. These are body-focused, so you're assessing skin integrity, looking for infection risk. The guide even mentions chocophagia in the glossary, swallowing pulled hair, which can cause serious internal blockages, a major safety concern to be aware of.
So knowing the typical manifestations from the guide really flags specific safety checks you need to make.
Okay, so we've assessed anxiety levels using Peplo, maybe identified features of a disorder. What does the guide say about intervening? Does it tailor the approach based on that anxiety level?
It does, very clearly. For mild to moderate anxiety, the guide emphasizes therapeutic communication. So open-ended questions, exploring feelings, active listening, staying calm, patient teaching, and problem solving. Possible and encouraged here.
But for severe to panic levels, complex talk is out. The guide says your focus shifts entirely. Provide for safety, stay with them, calm environment, reduce stimuli. Meet physical needs fluids, rest. Use firm, simple, short statements. The guide also makes a point about basic needs like nutrition, hygiene, grooming for all these patients, as severe symptoms can really impair self-care. That's a core nursing intervention.
So directly loops back to prioritization, handle the immediate crisis, the severe anxiety first. Then you can think about teaching or more complex stuff once they're calmer.
Exactly. Safety, stabilization first. Then the guide gets into treatment modalities, which brings us right to medications and patient teaching.
Okay, meds. Yeah. It lists SSRIs, SNRIs, benzodiazepines, buspirone, others too. Based only on this guide, what are the absolute critical points for patient teaching and safety?
The guide puts a big spotlight on benzodiazepines. It notes their quick onset is useful for acute anxiety relief. But, and this is crucial teaching from the source, they're typically for short periods. Why? Big risk of dependence and significant withdrawal symptoms if stopped abruptly. That's a critical teaching point from your guide. Warn patients about dependence, stress taking them exactly as prescribed, and never stop suddenly without talking to the prescriber.
Okay, that's a huge safety point, the dependence and withdrawal with benzos. What else for meds generally?
The guide gives general teaching for anti-anxiety drugs. Avoid alcohol and caffeine, they can worsen anxiety or interact badly. And a big one, do not change the dose or frequency yourself. Talk to the prescriber first. It also mentions FDA approvals for specific disorders, even pediatric use sometimes, which is a detail worth noting.
So med teaching from this guide is really heavy on safety. Dependence risks, interactions, adherence.
Got it. What about the non-drug therapies? Modeling, systematic desensitization, flooding, thought stopping. These sound like things you'd need to explain or reinforce. Absolutely. These are behavioral therapies, and the guide describes them pretty clearly. Knowing the basics helps you teach patients about their options or support the therapy they're getting. Modeling. Therapist or someone shows the appropriate behavior in a feared situation, patient imitates. Simple concept to explain.
Okay.
Systematic desensitization. Gradually introducing the feared thing, step by step, while the patient uses relaxation techniques. Least scary to most scary. You can teach the patient about this gradual process, flooding. The guide contrasts its exposure to a lot of the feared thing all at once for a prolonged time. Shows them they can survive it, the anxiety eventually fades. Teaching involves preparing them for intensity, but also reassuring them about the process.
That sounds intense.
It can be. And thought stopping, a technique to interrupt an unwanted thought, like an obsession. You literally think or say stop, and then switch to a pre-planned alternative thought. You could definitely teach or coach a patient on this one directly based on the guide's description. So yeah, understanding these basics from the guide is key for patient education. It empowers them.
And the guide mentions those brain-based therapies too, like gamma knife and deep brain stimulation for really severe resistant OCD. Good to know those exist as options, according to the source, even if they're specialized. Okay, let's tie this all back to the exam focus. Safety, prioritization, medication, and patient teaching.
Right. So the guide consistently points to patient-centered assessment, considering their culture, their past coping strategies. That's foundational for tailoring your teaching and care. And remembering to assess anxiety levels using Peplaw's model, just like the guide lays out, that's your fundamental tool for prioritizing. Severe or panic means immediate safety actions, stabilization before anything else.
Right.
Medication teaching, as we pulled out, is non-negotiable for safety and adherence, especially those warnings about benzodiazepines from the guide. And understanding the basics of those behavioral therapies allows you to effectively educate and support your patients through their treatment. The guide also mentions comorbidities and risk factors. Knowing those helps you anticipate potential issues, like substance use might complicate anxiety, hoarding creates physical risks. Recognizing that helps you build safety into your plan.
So we've really dug into this study guide, pulling out those core concepts for anxiety and OCD, but always looking through that lens of safety, prioritization, meds, and teaching what you need for the exam. From knowing how anxiety levels change everything to spotting maladaptive coping, identifying those critical disorder features, and getting the key points on treatments, this source gives you a solid base. Remember to ask why as you review. Why does this assessment finding matter? Why this intervention for this level?
Yeah, exactly. Think practically. How would knowing this info from the guide actually change what you do or say? If you walk in and your patient shows signs of severe anxiety, as described, how does that immediately change your priorities compared to someone in moderate anxiety? Or how does identifying that a patient uses, say, splitting, influence how you try to communicate or build trust based on what the guide implies about therapeutic communication?
So thinking about that way,
Yeah.
what really stands out after digging into this material with those filters? Like, how does understanding hoarding disorders features or the physical symptoms of a panic attack straight from the guide immediately bring specific safety issues right to the front of your mind?
That really raises a key question for you, doesn't it? It's not just about memorizing symptoms or drug names from the guide. It's about how integrating all this, the anxiety levels, the coping styles, the disorder features, the treatment principles, lets you proactively protect your patient's safety and tailor everything you do, especially your teaching, to where they actually are in that moment.
Definitely something important to reflect on as you keep studying.